and it's very different as well if it's caused by the trauma, and especially iatrogenic trauma happening in a hospital, not coming through the ER. So the management of the active limb ischemia varies according to the location, extension of the occlusion, and of course the duration, because when otherwise healthy patients get an embolization, they can tell you exact time when it happened. Like it happened like 9:47, doctor, I remember it's sudden pain. But it's very different if it is like old Baba, 80 years old, post multiple interventions before, and he calls the son saying like, my leg is hurting, and the son is saying, yeah, but Baba has been always like complaining about something, these are the delay cases, and it differs. So after the first very important decision about the viability of the limb, you have to decide about how you're going to manage the patient, either open or endovascular. And according to the guidelines, you should make this decision according to the local resources and the patient factors. How long and where is the occlusion, what is the cause of the occlusion, and then the severity of the ischemia itself. According to the literature, we don't really have like a very strong lead in regard to the data, what is really better. So when you decide to go for endovascular and you put aside the option of Fogarty catheter, then you have to decide between catheter-directed thrombolysis and mechanical thrombectomy. And so thrombolysis was the first option, and first endovascular option is very effective. It's indicated in all patients. There is no contraindications and viable limb according to the literature. It has a specific complications. The most threatening is the bleeding. Even so is the catheter-directed thrombolysis. We don't really see like fatal bleeding very often. It's because getting the thrombolytic agent inside the thrombus, and it's very effective as we know. So, but by time, mechanical thrombectomy is gaining more and more popularity. And what is actually the biggest advantage is the rapid revascularization. Because for thrombolysis, you have to wait 6, 8, 12, 24 hours. And according to the Pearl registry, it's advised to be actually the first-line treatment. So, to choose in between these two, it's sometimes not easy, and also your resources are very important. The treatment choice is supposed to be based on the clinical scenario, and it's also about the operator expertise and availability of the device as well. So very often we combine these two methods. So, and in both versions, you might start with the thrombolysis to macerate the thrombus and then suck it out. Or the other way around, you start with mechanical thrombectomy, and whatever stays there, you go for lysis if you cannot reach it with mechanical thrombectomy. There are many devices on the market with a different action, and there is no head-to-head data, so you cannot really say which one is the best. I just want to mention the Pearl registry, which was done with an angiojet. And what is very interesting, what I like about is you can see that half of the procedures were actually completed with the thrombolysis. So again, despite like data, it's very difficult to say what is really the best treatment, and it's very uncertain. You should make your decision according to your local conditions and circumstances. In our institution, we use mechanical thrombectomy devices. It's a Rotarex and angiojet. They both are working with the suction, but there are like differences. The angiojet is more gentle. It's a very reliable device. What I like about it, you have also 4 French catheter, which can go all the way to the PVLs. It's very flexible. And you have this Parapulse mode, which you can combine with the thrombolysis, and we use this very heavily. Rotarex, on the other hand, we use for the inside thrombosis, usually combined with the atherosclerotic lesion, because it's combining the action of atherectomy and thrombectomy. So it's much stronger device than angiojet with very strong suction, and you can use it for mixed thrombus, the active and on the top of as the upper respiratory flank itself. But it's much more tricky. It's operator dependent. The learning curve of rotarex is longer than the angiogen. And this is the example of a case last week, the complete thrombosis of popliteal artery. There is a short video which you can see moving the rotarex device step by step with a flushing through the sheath, which is very important. And the reason I'm putting this case, you can see the quite rare complication of bleeding. You can see the extravasation of second run of the rotarex device, which we fixed with a prolonged balloon, and this was the end result of the procedure. So, in conclusion, you're supposed to choose your treatment and the management choice according to patient's need. It's supposed to be individual, depends on your own experience as well. And my personal advice is to choose one device, to get a good training, and try to get the as best experience as possible. Thank you very much.
We will give all the questions after the sessions because there is a lot of interesting topics. Good discussion.
Second presentation, CFA and vascular approach, Dr. Konstantin Slavovakis from Germany. He's
No.
Do we have the
That's online.
welcome, Doctor.
Online setting. My name is Konstantinos Stavlakis. I'm consultant of vascular and vascular surgery, and my topic today is the endovascular treatment of CFA disease. There is no doubt that surgical treatment is the first line treatment option for most patients with CFA disease, who have excellent primary patency rate of 96% at least at 7 years, and this is something that the vascular treatment option cannot achieve in any endovascular bed. Nonetheless, what we know from the literature is that the CFA disease CFA endarterectomy is not a straightforward procedure as we thought in the past. We have combined morbidity and mortality of 50%, and there are certain independent risk factors like COPD, end-stage renal disease, Rutherford class 6, and emergency setting, which are associated with increased risk for perioperative complications. And of course, all of us have these patients that we don't want to treat by endovascular means. Patients with hostile groin, with wound infections in the groin, and of course these obese patients that we have to treat in our everyday practice. So the question is, are these patients eligible for endovascular treatment? And endovascular treatment can be an option for these hostile groin patients. There is very important work done in the UK, and the two-center analysis. The college evaluated the eligibility of patients undergoing CFA endarterectomy for endovascular repair. And what they found out is that in 78% of the patients, endovascular treatment would be possible and feasible. But what about the results of endovascular repair on the long term? What we know from the TECO trial is that stenting therapy is associated with comparable clinical and radiological outcomes with CFA endarterectomy at least up to years. And we have also our own experience. We published it a couple of years ago. What we found out is that the vessel preparation of the groin is associated with improved results compared to DCB alone. We wait, of course, for the results of the PESTO AFC trial, which will evaluate the performance of atherectomy and DCB against surgery. The preliminary results also of the Supera stent are quite promising. And here we have a trial, the SuperSearch trial, which will be published the upcoming years, which will compare the outcomes of Supera with open repair. A new kid on the block is, of course, the CFA lithotripsy and BCP angioplasty. I'm happy that we will publish our results in a couple of weeks in Journal of Vascular Therapy. When we analyzed the first 33 patients treated by IVL and BCP, we found a very good freedom from TLR. Nonetheless, the primary patency rates weren't that promising. We have almost 8% primary patency rates at 12 months. Here I have to say that most of these patients were asymptomatic. That's why they didn't undergo any secondary procedure. And this is the difference between TLR and primary patency. There are, of course, colleagues who say that will never go for endovascular repair of the groin for many reasons. First of all, this is a very mobile vessel, and the shortening, twisting, or bending of the groin will, of course, be a challenge for endovascular repair. Second, I don't want to use a profound artery. Third, we cannot treat challenging lesions. So, of course, I don't want to use an access vessel. Well, some of them are myths, I would say, and the first myth is that the CFA is a mobile vessel. What we know from the literature is actually that the common femoral artery is a fixed arterial segment, and the CFA artery doesn't really move. The truth is that the CFA is a very fixed vessel between two very flexible vessels, namely the external iliac artery and the SFA. And as you see in these angiograms from Lorenzo Patrone, was very interesting, superior placement in the groin. As you see, the CFA doesn't really move. Even when we have a flexion of the hip, we see in these angiograms clearly that the CFA disease is actually a very fixed arterial segment and not a very mobile vessel. The second thought is that we might use an access vessel. This is again angiograms from Lorenzo showing that you can actually puncture a superior stent and introduce a sheath to perform peripheral procedures. And you can do it easily for 6 or 7 French sheaths. Me personally wouldn't go for bigger devices for bigger access, but you can easily perform 6 and 7 French procedures through a superior stent. And when we talk about using an access vessel, I would say from my experience as surgeon that many times the open repair is associated with a loss of an access vessel. Wound complications are not uncommon. The groin, and as you see in these hostile situations, it's very difficult to perform any kind of endovascular repair in the future, going through muscle ups, etc. Which are my personal indications for endovascular treatment? First of all, hostile groin, when you have restenosis or bypass anastomosis stenosis, severe obesity, and sometimes for access site complications. We don't have many tools to treat endovascular, to treat the CFA. Nonetheless, I think that the use of atherectomy, IVL, BCB angioplasty, when we need a stent, we should use a Supera. These are the best, at least my eyes, treatment options for treatment of CFA disease. Restenosis is not that uncommon for CFA disease. As you see here in this patient, we have the patient underwent a CFA endarterectomy, came back again with restenosis of the groin. It was the second stenosis after 2 open repairs. Went for atherectomy for the Hock device, BCB angioplasty with a very good result. And what I find very interesting for the Hock device is that you can treat easily eccentric lesions, even dissections. We should not forget that the CFA disease most of the times on the posterior wall of the vessel or very eccentric. In this case, post-puncture dissection of the CFA, the patient was on triple therapy with aspirin, Plavix, and Xarelto. That's why I decided to go for endovascular repair. Went for atherectomy, BCB with a very good result. Again, an example of an eccentric lesion treated with a Hock device, BCB angioplasty with a very good result. We gain more and more experience with the treatment of bypass anastomosis stenosis. This is a patient with a subtotal lesion of the groin. This is a prosthetic bypass from the functional to the tibial arteries to the anterior tibial artery, performed Phoenix atherectomy, reduced the plaque burden, and then went for DCB angioplasty with a very good result. The reason why I'm trying to prepare the groin prior to DCB angioplasty is first to reduce the risk for dissections, especially in these anastomotic lesions, very difficult to place a stent if you have a dissection because you have gel profunda most of the times. And then the second reason is I want to increase the drug uptake by debulking the atherosclerotic part of the plaque. Calcium can be easily treated nowadays, also with IVL angioplasty. You see here that the intravascular toltropsin combination with DCB is associated with very good result. Patients with significant calcium in the groin was treated with IVL and DCB. The same for the profunda. You can easily treat the profunda lesions nowadays. Again, IVL with DCB with a very good result from the acute result, but also 6 months after the procedure. Sometimes it's inevitable to deploy stent, especially patients that are no option when you have dissections or the results of vessel prep and DCB are not good enough. In this case, prepare the groin with the IVL and afterwards placed superior. So the question is, can we treat every lesion by the vascular means? Of course not. It might be possible or feasible, but I don't think that's meaningful. And these heavily calcified occlusions, I think that surgical repair is indicated. And although I saw some cases with access site complications that can be treated by the vascular means, I think that in these easy cases can be done, but surgery is still a good option when you have occlusions with a closure device, etc. Another good indications, of course, bleeding of the groin. In this case, I tried to cover the bleeding with the two Viaband grafts. Nonetheless, didn't have enough good sealing, so I used a vein interposition graft to treat this bleeding. Of course, I had to remove the Viabands that were planned. To conclude, surgery is still the gold standard for CFA disease. Nonetheless, is associated with a significant morbidity and mortality. Endotherapy is useful for patients with unfit for surgery, with restenosis of the groin, high risk for complications, etc. And most patients are nowadays considered fit for or considered at least could be treated by vascular means. Vessel prep and DCB is my first line treatment option, and when I need a stent, I would go for a superior deployment. Thank you very much for your attention.
Thank you, Dr. Konstantinos. We shall proceed to the next speaker, Dr. Michael Lichtenberg. Of course, you all know him. He's the Chief Medical Officer in Arnsberg Clinic. Dr. Michael will attack a very interesting subject, or the preparation strategy for the lesions to endovascular, before endovascular disease. Thank you. Super. Thank you very much. Pleasure to be here to talk about lesion preparation. I think a very important topic in these days, as we learned in the past that standard balloon angioplasty causes a lot of issues in terms of insufficient lumen gain, recall, barotrauma. And whenever we see these kind of issues, then we are forced to implant stent, and we are fully aware that stent implantation is also associated with restenosis and reintervention. So we need to come out of this vicious circle, and therefore I think we need to discuss what is the reason why we should do something different. And the reason is that we have compliance mismatches, especially BTK. We have diseased areas, we have non-diseased areas, and this mismatch of diseased and non-diseased areas can contribute to recall and dissection. That means we have to modify the calcification, the wall stiffness by lesion preparation, and data are already existing for a couple of years, but probably we did not refocus on these data like these from Frank Baumann in 2014, where he just did standard balloon angioplasty in BTK vessels and found a significant recall in most of the treated vessels even after 50 minutes. So that means loss of patency within minutes. And I think whenever we talk about our CLI patients, we need to do something different. So that means we need to tackle calcification to get out of this vicious circle, to improve technical outcome, procedural outcome, long-term patency, and to prevent long stent implantation. And there are a lot of treatment alternatives now on the market. A lot of these devices are shown here during the conferences. New devices are coming. These are the established technologies, unfortunately, but now we do not know which is the best device in the best indication. So we need to set up randomized trials to find out which device in which situation. Just to focus on some more new devices, this is a device which now came to the European market. This is the Bicross device, the 2-in-1 device, a device with an atherectomy tip, as you can see here, the expandable tip, so we can treat lesions from 8 to 3 millimeter diameter vessel. And this device also has a high suction capability, so you can also perform thrombectomy with this device. You see the specification of this Bicross device. It has 2 external nitinol wires which are forming the expandable tip of this Bicross device. And with this device, you can treat, as just said, 3 millimeter vessels distally and up to 8 millimeter proximal. Just some case examples here, the distal SFA. And another great advantage of this device, you can even use this device without guide wire events. So we treated this lesion just with the device, went through the device, divided it, and performed DCB angioplasty. This is a TP trunk, high-grade stenosis, 3 millimeter diameter, so sufficient for this device, performed atherectomy and DCB angioplasty. And this is long SFA complete occlusion. We use this device without wiring, so use just the device to penetrate the occlusion, perform atherectomy, then POVR, and of course DCB should be done afterwards. New devices are a sign of active atherectomy devices coming. This is a new device called the Serenator device, a serration technology which has 3 serration strips on a balloon, so you can use it like a standard balloon, just using serration angioplasty. It comes in diameter 2.5 to 3.5 and balloon length up to 120 millimeter. It needs a 6 French access and runs over 0.14 guide wire. You see on the right side IVUS analysis pictures after using this device. You can see how this device, how efficient this device cracks the media intima calcification, and also on OCT you can see the serration answers here in the vessel wall cracking calcification. A publication and a study was recently done for this device, the Prelude BTK study, where we analyzed the efficacy and safety of this device in BTK vessels. Here are the freedom for clinical driven TLR data at 6 months, 97.7 device, again, patient with critical limb ischemia. And so this device could just be used as a standard balloon technology, just balloon it, and you're done after 2 minutes. These are the 6-month Rutherford results for this Prelude data. Of course, the patient improved after this efficient plug removal and needle preparation, so 70% of the patient improved in 1 or more RCCs at 6 months. Here are the total freedom for minor and major amputation listed, so after 6 months, freedom from target limb minor amputation, major amputation 97.7%. You see some subgroup analysis using the OCT device for analysis after using this duration. You see the answers, post-serenators in the vessel walls, so the cracking of the calcification. What we are doing now is to analyze if the device can prevent recall after 50 minutes. So we are doing a randomized trial together with colleagues from Stanford. It's a collab adjudicated study analyzing if this device prevents recall. Just a case example from this trial. Long PT occlusion here used this device. We did an IVUS analysis, pre-serenator, see this functional occlusion. Good lumen gain after using the serenator. After 50 minutes, no recall based on IVUS analysis. Contradictory to that, POVA patients, you see a short lesion in the TP trunk and in the TP artery, you see after 50 minutes, even on angio, significant recall answer. And based on IVS, you see a recall in the situation of 30%. So that seems to prove the Baumann publication, POVA is not a sufficient tool for BTK intervention. New devices are coming, and this is the new shockwave future. It's called the Apollo IVL system. It's a shockwave using laser technology, not electricity turning into mechanical power. So it's using laser technology turning into mechanical power. The real advantage will be for this system that this can be coded as laser atherectomy, so good argument for reimbursement. And the Restore BTK trial, which just has started, will focus on efficacy and safety and hopefully see good outcome data. The final device I would like to show you, a new atherectomy device, is a soundbite technology. It's a shockwave wire penetrating CTOs. It works like the shockwave technology. It's a wire which receives at the tip shockwaves, and with that you can cross and modify plug CTOs, so you can penetrate long occlusions in the SFA or BTK to get a wire down. A very helpful tool actually, especially in very calcified lesions with this soundbite technology. And here's this device. Unfortunately, the sound is not on. How it penetrates to this air cap here and penetrates the calcification. It's not attacking soft material, so it's not injuring soft material like you see here. The shockwaves are not attacking any kind of soft wall or soft tissue as shown here. So inclusion beyond pre-dilatation, optimal PTA adjunctive vessel prep can help to achieve acute success better and easier with larger, more stable acute gain, lower dissection, better predisposition to drug absorption. What we definitely need now are head-to-head comparison for these different technologies to really learn which device and which indication. Thanks a lot.